Congenital muscular dystrophies present with generalized weakness and hypotonia at birth, distinguished by dystrophic muscle biopsy changes, including endomysial and perimysial connective tissue proliferation and muscle fiber replacement by fat. CPK elevation varies significantly, often markedly elevated at 5 to 10 times normal in CMDS versus normal or mildly elevated levels in congenital myopathies. The progressive nature of CMDS contrasts sharply with the static or slowly progressive course of congenital myopathies. CNS involvement frequently occurs in CMDS, particularly the syndromic forms like Walker-Warburg syndrome, muscle-eye brain disease, and Fukuyama CMD. These conditions result from defective alpha-dystroglycan glycosylation, compromising muscle membrane integrity and causing neuronal migration defects. Muscle biopsy in CMDS shows little evidence of necrosis or regeneration despite the dystrophic changes, while immunocytochemical studies help distinguish between different CMD subtypes. The genetic classification includes Merosin-deficient and Merosin-positive forms, with LAMA2-related CMD being the most common classic form. Merosin-deficient CMD, MDC1A, represents the most common classic CMD form, caused by LAMA2 gene mutations affecting the alpha-2 subunit of Merosin in the extracellular matrix. These infants present with marked neonatal hypotonia, generalized weakness, and early contractures affecting multiple joints. Characteristic white matter changes appear on MRI after 6 months, showing diffuse increased T2 signal intensity due to Merosin absence in cerebral vessel walls. Epilepsy affects 1/3 of patients, though cognition typically remains preserved. Walker-Warburg syndrome represents the most severe syndromic CMD form, with eye abnormalities including retinal dysplasia, cataracts, and glaucoma. Brain malformations include cobblestone lissencephaly from glial limitons disruption. Few infants survive beyond months without modern medical support. Fukuyama CMD occurs mainly in Japan and involves intellectual disability alongside muscle weakness. Like other syndromic CMDs, it results from defective glycosyltransferase function affecting alpha-dystroglycan post-translational modification, leading to both muscle membrane compromise and neuronal migration defects during brain development. Congenital myopathies are characterized by static or slowly progressive weakness, with preservation of muscle fiber architecture contrasting with the dystrophic changes seen in CMDS. CPK levels remain normal or show mild elevation, rarely reaching the 5 to 10-fold increases typical of muscular dystrophies. This biochemical distinction aids differential diagnosis in hypotonic infants. Core myopathies represent approximately half of all congenital myopathy cases, followed by Nemaline and centronuclear myopathies, each comprising about 15%. The severity spectrum ranges widely. Severe forms like MTM1 and ACTA1 disorders can be fatal within the first year, while milder cases may show improvement over time, with some achieving independent ambulation. Unlike CMDS, congenital myopathies typically lack significant CNS involvement, though extraocular muscle weakness can occur in centronuclear myopathy. Muscle biopsy reveals specific structural abnormalities, cores in core myopathies, rods in Nemaline myopathy, and centrally located nuclei in centronuclear myopathy, rather than dystrophic changes. RYR1 mutations account for most core myopathies and carry malignant hyperthermia risk, requiring perioperative precautions. Nemaline myopathy, derived from the Greek word nema, meaning thread, is the most likely congenital myopathy to present in the neonatal period. The characteristic thread-like rod bodies stain red on Gomori trichrome, creating the pathognomonic histologic appearance. These rods typically appear subsarcolemmal, with intranuclear rods specifically seen in severe neonatal forms. Severe neonatal presentation involves profound weakness of facial, bulbar, and respiratory muscles, requiring extensive support including respiratory assistance, frequent suctioning, and gastrostomy tube feeding due to swallowing difficulties. More than 10 genes are associated with Nemaline myopathy, with NEB causing most autosomal recessive cases and ACTA1 causing most autosomal dominant cases. The most severe cases, often caused by CTA1 mutations, carry poor prognosis with rare survival past the first year of life. However, survivors with milder presentations may show improvement over time, with some achieving independent ambulation. Many will still require ongoing respiratory assistance due to nocturnal hypoventilation and may develop failure to thrive or scoliosis. Reduced fetal movements and polyhydramnios frequently occur in severe forms, with arthrogryposis complicating the clinical picture. Congenital myotonic dystrophy results from CTG trinucleotide, repeat expansion in the DMPK gene located on chromosome 19q13.3. Normal individuals have 5 to 27 repeats. Classical myotonic dystrophy patients have 50 to 1,000 repeats, while congenital cases typically have over 1,000 repeats. The transcribed CUG-RNA repeat negatively impacts DMPK expression and affects other genes, including SIX5 and CLC1 gene splicing. Genetic anticipation is a hallmark feature, with progressively earlier onset and more severe presentations in successive generations. This phenomenon occurs due to expansion instability during transmission, particularly during oogenesis rather than spermatogenesis. Maternal inheritance characterizes the congenital form, with rare exceptions. This pattern relates to oligospermia in affected males, and the greater propensity for large repeat expansions, greater than 1,000 repeats during oogenesis compared to spermatogenesis. The earlier the disease onset and more severe the clinical expression in the mother, the greater the risk for congenital myotonic dystrophy in offspring. However, the condition can still occur in children of only mildly affected mothers due to somatic instability of the CTG repeat. Congenital myotonic dystrophy presents with the distinctive tent-shaped mouth featuring an inverted V upper lip, creating the characteristic carp mouth appearance. Facial diplegia and bilateral petosis complete the recognizable facial phenotype that often provides the initial diagnostic clue. Severe hypotonia and generalized weakness are profound at birth, with weakness characteristically more severe in distal muscles than proximal ones, the opposite pattern of most neuromuscular conditions. Respiratory distress results from both muscle weakness and pulmonary immaturity, with poor central respiratory control contributing to morbidity. Pregnancy history typically reveals polyhydramnios from failure of fetal swallowing and decreased fetal movements, with premature delivery common. Delivery complications include prolonged labor and postpartum hemorrhage due to poor uterine contractions. Neonates frequently require resuscitation and face mortality risks associated with neonatal encephalopathy. Examining the mother provides the essential diagnostic clue. Despite the maternal inheritance pattern, mothers may be unaware of their diagnosis due to subtle symptoms. Clinical and electrographic myotonia are absent in neonates, developing later in childhood, making maternal examination crucial for diagnosis in the neonatal period. Testing for grip myotonia involves asking the mother to squeeze her hand tight and quickly let go. Inability to rapidly release grip indicates myotonia. Percussion myotonia can be elicited by tapping the thenar eminence or brachioradialis muscle, observing for sustained muscle contraction followed by delayed relaxation. Physical examination of the mother should assess for characteristic facial features including frontal balding, petosis, facial diplegia, temporal wasting, and cataracts. These features may be subtle, and the mother often remains unaware of her diagnosis until her child's presentation prompts evaluation. Maternal examination is essential because grip and percussion myotonia are not present in neonates with congenital myotonic dystrophy. These signs develop later in childhood. The clinical phenotype in newborns lacks the myotonic phenomenon that defines the condition in older patients, making maternal assessment the critical diagnostic link. This examination should be performed routinely when evaluating any hypotonic newborn, as it provides immediate diagnostic direction. The combination of a hypotonic infant with typical facial features and maternal myotonia allows clinicians to proceed directly to genetic confirmation rather than extensive workup, expediting diagnosis and management planning. Congenital myasthenic syndromes comprise a growing number of heterogeneous genetic disorders, characterized by failure of neuromuscular transmission secondary to genetic defects in neuromuscular junction proteins. Unlike acquired myasthenia gravis, CMS are not autoimmune conditions. They result from inherited presynaptic or postsynaptic defects affecting acetylcholine receptors and related proteins. The hallmark clinical feature is fatigable muscle weakness, involving extraocular, bulbar, respiratory, and limb muscle systems in different combinations. This fatigability with activity distinguishes CMS from other neonatal neuromuscular conditions and can be subtle early in presentation, sometimes delaying diagnosis by years. A significant proportion of CMS cases present in the neonatal period or early infancy, with episodes of respiratory distress or apnea being key warning signs. In retrospective reviews of early presenting CMS cases, 8 out of 11 patients presented at birth with severe respiratory distress, in addition to hypotonia, weakness, and contractures. Laboratory evaluation typically shows normal CPK levels, and muscle biopsy is either unremarkable or shows only mild, nonspecific findings. EMG with repetitive nerve stimulation historically provided diagnostic guidance, but increased availability of genetic testing now allows more targeted diagnosis given the phenotypic variability in presentation. DOK7 congenital myasthenic syndrome presents with a distinctive neonatal phenotype that includes stridor from bilateral vocal cord paralysis, a unique presentation that should immediately raise suspicion for this specific CMS subtype. This vocal cord paralysis creates significant respiratory distress, requiring prompt recognition and intervention. The combination of stridor, respiratory distress, and feeding difficulties may necessitate intubation and ventilator support for some patients. The bilateral vocal cord involvement distinguishes DOK7-CMS from other neuromuscular conditions and provides an important diagnostic clue in the evaluation of the hypotonic newborn with respiratory compromise. Treatment response is crucial to recognize. DOK7 patients respond to oral albuterol rather than pyridostigmine, which is the standard treatment for most other CMS subtypes. The typical dosing is 2 to 4 milligrams orally, 2 to 3 times daily. This differential treatment response makes specific genetic diagnosis essential, as pyridostigmine may actually worsen certain CMS types. Respiratory support remains important even with albuterol treatment, with non-invasive ventilation preferred since some patients improve with age. Nutritional support with gastrostomy tube should be considered for persistent feeding difficulties related to the bulbar involvement and vocal cord paralysis. Cholinacetyltransferase, CHAETS, congenital myasthenic syndrome presents with a particularly severe neonatal phenotype characterized by life-threatening apneic episodes that distinguish it from other CMS subtypes. These episodes of apnea occur later in infancy, creating ongoing risk that requires careful monitoring and family education. Marked bulbar weakness dominates the neonatal presentation, leading to significant feeding difficulties from birth. The combination of hypotonia and respiratory insufficiency in the neonatal period, followed by the development of episodic apnea, should raise suspicion for CHAT deficiency. The pathophysiology involves mutations affecting choline acetyltransferase, the enzyme responsible for acetylcholine synthesis. This presynaptic defect results in decreased acetylcholine availability at the neuromuscular junction, leading to the characteristic pattern of weakness and potentially fatal apneic episodes. Recognition of this specific CMS subtype is critical because the life-threatening nature of the apneic episodes requires vigilant respiratory monitoring and potentially different therapeutic approaches compared to other CMS forms. The bulbar involvement from birth combined with the later development of apneic episodes creates a distinctive clinical pattern that, when recognized, can guide appropriate genetic testing and management strategies. Maternal immunoglobulin G antibodies directed against acetylcholine receptors cross the placenta readily, but typical features develop in only 20% of infants born to mothers with myasthenia gravis. No correlation exists between maternal antibody titers or disease severity and the development of neonatal myasthenia, requiring monitoring of all at-risk newborns regardless of maternal symptom severity. The mother may have less obvious disease, be in remission, or not show clinical manifestations until after pregnancy, making maternal history crucial. Interestingly, an inverse relationship exists between maternal disease duration and the incidence of neonatal myasthenia. Critical timing considerations define monitoring protocols. While symptoms can occur immediately after birth, they may not develop until 2 to 4 days post-birth. Newborns of mothers with Myasthenia gravis should be observed between 2 and 4 days post-birth to capture delayed presentations. However, onset after the 3rd day has not been reported. This transient condition resolves spontaneously as maternal antibodies are metabolized. Recovery occurs in 90% of infants within 2 months, with an average treatment duration of 4 weeks when intervention is required. Management must be early and vigorous because affected infants can deteriorate rapidly. Pyridostigmine is indicated specifically for cases with maternal AChR antibodies at 1 to 2 milligrams per kilogram per dose orally every 6 hours. Close monitoring is essential since excessive doses cause diarrhea, increased secretions, muscle fasciculations, and cholinergic weakness. Intravenous immunoglobulin can be considered in severe cases where standard anticholinesterase therapy proves insufficient. This intervention provides additional maternal antibody neutralization for critically ill neonates with severe respiratory or bulbar compromise. Supportive care forms the cornerstone of management. Small, frequent nasogastric tube feedings should be given with early ventilatory support considered when respiratory function is compromised. Tube feeding and artificial ventilation are usually not required for longer than 1 to 2 weeks in most cases. Complete resolution occurs predictably. The average duration of treatment is 4 weeks, with recovery in 90% of infants within 2 months, as maternal antibodies are metabolized and cleared from the infant's circulation. Disease activity disappearance is monitored clinically by assessing responses to gradual decreases in anticholinesterase dosing. When CPK levels are normal or mildly elevated in a hypotonic newborn, SMA testing should be the initial genetic evaluation. Approximately 95% of individuals with SMA are homozygous for deletion of exon 7 of the SMN1 gene, making this high-yield first-line testing. SMN2 copy number must be included alongside SMN1 testing because it directly modifies phenotype severity. A direct relationship exists between the number of SMN2 gene copies and age of disease onset, with SMA type 1 phenotype correlating with the lowest SMN2 copy numbers. This information guides treatment decisions and prognostic counseling. Rapid turnaround is critical for treatment timing. 3 FDA-approved therapies, nusinersen, onasemnogene abeparvovec, and risdiplam, transform SMA from a uniformly fatal condition to a treatable disorder when initiated early. Recognition that early treatment significantly augments outcomes makes expedited diagnosis essential. Newborn screening provides the optimal pathway when available. SMA is nationally recommended for newborn screening in the United States, with nearly 3/4 of states implementing screening as of May 2021. Any infant with positive newborn screen requires confirmatory genetic testing of SMN1 and SMN2 copy numbers alongside immediate neurology consultation for treatment planning. Gene panels should be used after SMA. Testing is negative, and when the phenotype suggests a specific diagnostic category. This targeted approach optimizes diagnostic yield while controlling costs and avoiding unnecessary broad testing. Congenital myopathy panels target conditions like Nemaline myopathy, central core disease, and centronuclear myopathy when CPK levels are normal or mildly elevated, and specific histologic features or clinical patterns suggest these diagnoses. The main utility of muscle biopsy now consists in identifying particular types of congenital myopathy and directing genetic testing towards smaller panels of genes. Congenital muscular dystrophy panels focus on conditions like Merosin-deficient CMD, dystroglycanopathies, and collagen 6-related disorders, when CPK is significantly elevated above 5 times normal. These panels have been separated into 7 subtypes based on recent genetic discoveries and mechanistic approaches. Neuromuscular junction panels target congenital myasthenic syndromes when fatigable weakness and specific clinical patterns like DOK7 stridor or CHAT apneic episodes are present. With increasing availability of genetic testing and decreasing costs, it's becoming feasible to start workup with genetic testing and employ muscle biopsy only if the first round of genetic tests fails to reveal abnormalities. Whole exome sequencing should be considered when panel testing is negative or inconclusive, when complex phenotypes don't fit standard categories, or when family history suggests a genetic etiology not captured by available panels. This represents the next tier of genetic evaluation after targeted approaches fail. Diagnostic yield in pediatric neuromuscular cases ranges from 25 to 49%, making WES a valuable tool despite its limitations. The relatively high yield justifies its use when initial genetic testing approaches are unrevealing, particularly in critically ill neonates, where rapid diagnosis impacts management decisions. Trio testing, involving the patient plus both biological parents, increases diagnostic yield significantly. This approach has been used to evaluate critically ill neonates and helps distinguish de novo mutations from inherited variants, improving interpretation of results and providing more definitive genetic counseling. WES provides substantial diagnostic capability for complex neuromuscular presentations when standard approaches fail, though understanding its limitations ensures appropriate utilization and prevents missed diagnoses requiring alternative testing strategies. Whole exome sequencing cannot detect trinucleotide repeats due to technical limitations, missing critical diagnoses with genetic anticipation, such as congenital myotonic dystrophy. This represents a significant gap requiring specific gene testing when clinical suspicion warrants evaluation for repeat expansion disorders. Copy number variants may escape detection secondary to probe size limitations, potentially missing deletions, duplications, and other structural variants that cause neuromuscular disease. Coverage gaps in certain genomic regions further limit diagnostic capability, particularly in areas with repetitive sequences or complex genomic architecture. Chromosomal microarray provides complementary testing to detect copy number variants that WES might miss. This concurrent testing strategy maximizes diagnostic yield by capturing both single nucleotide variants and larger structural genomic changes that contribute to neuromuscular phenotypes. Specific gene testing remains necessary for trinucleotide repeat disorders when clinical features suggest conditions like congenital myotonic dystrophy, despite negative WES results. Understanding these limitations ensures appropriate test selection and prevents missed diagnoses in conditions requiring targeted approaches beyond standard exome analysis.